Okay, let's dive straight into this explainer on long QT syndrome and really examine how the human heart's incredibly intricate electrical circuit can suddenly just glitch. We often think of the heart simply as a mechanical pump, right? But before that pump can squeeze even a single drop of blood, it relies on a perfectly timed electrical spark. So today, we're going to look at what exactly happens when that timing is thrown off, specifically focusing on a condition known as long QT syndrome or LQTS. Here is our quick roadmap for decoding this condition. We'll kick things off with the heart's electrical glitch, move into the congenital causes, then look at acquired triggers, followed by spotting the warning signs, and finally, restoring the rhythm. So, Section 1, the heart's electrical glitch. To really wrap our heads around this, think of the heart kind of like a rechargeable battery. For a single heartbeat to happen, the lower chambers, the ventricles, have to electrically discharge. We call that depolarization. And then they have to quickly recharge, which is repolarization, so they're ready for the very next beat. Well, long QT syndrome is essentially a critical, dangerous delay in this specific timeline. The QT interval is just the medical term for the time it takes those ventricles to fire and reset. And when that process is prolonged, the heart's rhythm becomes highly vulnerable to some really dangerous short circuits. When you capture this on an electrocardiogram, an ECG, you can actually see that electrical lag. It shows up as this stretched out, prolonged wave, visually anchoring that delayed recharge phase we were just talking about. Now, that extra distance on the grid paper might look completely minuscule to the untrained eye, but in the fast-paced world of cardiac electrophysiology, those extra milliseconds are quite literally an eternity that can invite absolute chaos. The crucial point to understand here is that this delay doesn't just happen out of nowhere. It actually comes down to one of two very different culprits. You are either dealing with congenital LQTS, meaning someone is born with faulty genetics that build a defective electrical system right from day one, or you're looking at acquired LQTS. This is where environmental tripwires, things like drugs or mineral imbalances, disrupt a previously perfectly normal heart. Let's break both of these down. Moving right along to Section 2, congenital, born with it. If we zoom all the way down to the microscopic level, the heart's recharge phase depends entirely on these tiny doorways called ion channels, located in the heart muscle cells, or myocytes. Congenital LQTS happens when there are actual genetic mutations coding for these exact channels. Specifically, we're talking about mutations on chromosome 11p, involving genes like KCNE1 and KCNQ1. These mutations physically deform the potassium channels. In LQTS type 1, which happens to be the most common form, the specific channels responsible for the heart's rapid recharge phase are just broken. In plain terms, the microscopic doorways that are supposed to let potassium flow out of the cell during that critical reset phase are jammed shut. The potassium gets bottlenecked, and the whole recharge is severely delayed. Now, what's really fascinating here is the stark clinical difference between the two major congenital subtypes. Both of these can cause wildly fast, dangerous heart rhythms, tachyarrhythmias, but they present very differently in patients. Jervell-Lange-Nielsen syndrome is autosomal recessive, meaning you'd need a mutated gene from both parents. And remarkably, it is strongly associated with congenital deafness. Why? Because it turns out those exact same potassium channels are absolutely crucial for fluid balance in the inner ear. On the flip side, we have Romano-Ward syndrome. This one is autosomal dominant, but it has absolutely no associated deafness. It's just an incredible example of how a single genetic cellular defect can manifest across entirely different systems in the human body. Which brings us to Section 3, acquired, unintended drug triggers. So what if your genes are perfectly fine, but your heart's electrical circuit suddenly gets tripped up anyway? This is a massive question for both patients and healthcare providers, because it highlights the hidden dangers lurking right in our medicine cabinets. Acquired LQTS is very often iatrogenic, which is a fancy way of saying it's inadvertently caused by medical treatment itself. A surprisingly large array of commonly prescribed drugs can unintentionally block that potassium outflow we talked about. Sure, you'd probably expect antiarrhythmics, drugs actually meant to fix heart rhythms like quinidine or sotalol, to carry some risk. But look beyond the heart meds, because this is where it gets kind of wild. Everyday antibiotics used for common infections, like macrolides and fluoroquinolones, can do it. Routine medications for mental health, including most tricyclic antidepressants, some SSRIs, lithium, and antipsychotics like haloperidol or ziprasidone, literally all of these can artificially prolong that QT interval in an otherwise completely healthy heart. And the risk goes well beyond just medications, too. Your heart relies on a very specific, perfectly balanced mineral soup to conduct its electricity. A sudden drop in crucial electrolytes, whether we're talking low potassium, low magnesium, or low calcium, acts as a severe environmental tripwire. Even events happening entirely outside the chest cavity can trigger LQTS. Things like acute central nervous system insults from an ischemic stroke or an intracranial hemorrhage. Throw in endocrine disorders like hypothyroidism, or even rare nutritional issues like severe vitamin D deficiency, and you start to see just how deeply interconnected our overall systemic health is with our heart's electrical stability. Let's move on to Section 4, Spotting the Warning Signs. Knowing why this happens is great, but how do we actually spot the clinical features before a catastrophic event occurs? Well, the frightening reality here is that a lot of patients are completely asymptomatic, especially if the interval is only minutely prolonged. They feel totally fine. But once symptoms do finally appear, they escalate rapidly. It might just start as unexplained palpitations or a bit of dizziness. However, a major hallmark warning sign is sudden syncope, fainting. This is usually triggered by sudden exercise, intense emotion, or even just high stress. For some, tragically, the very first and only warning sign they ever get is full cardiac arrest. Because a slightly long interval can sometimes just be a normal, harmless variant in healthy people, diagnosing this condition requires absolute precision. Clinicians can't just guess based on symptoms. They have to hit specific, hard clinical thresholds for the QTC. That's the QT interval mathematically corrected for the patient's current heart rate. For males, the danger zone is firmly anything over 440 milliseconds. And for females, the threshold is slightly higher, sitting at over 460 milliseconds. But, as always in medicine, numbers on a page aren't quite enough on their own. To really solidify the diagnosis, clinicians combine those hard millisecond thresholds with a deep dive into the patient's history. They're looking for those unexplained fainting spells or a concerning family history of sudden death. They rely heavily on the ECG findings, and crucially, they utilize genetic testing to lock down a congenital diagnosis. Finding the exact mutation helps guide highly targeted long-term care. Finally, Section 5, Restoring the Rhythm. So once we've successfully diagnosed the glitch, how does modern medicine step in to prevent the whole system from short-circuiting? For the congenital form, we follow a very clear escalation of care. Step 1 is straightforward lifestyle modification, avoiding activities that suddenly stress the heart, particularly sudden immersion in cold water like diving or swimming, which can violently trigger arrhythmias. Step 2 is our first-line medical defense, beta blockers like propranolol, to blunt the heart's dangerous response to adrenaline. Now, if a patient doesn't respond to the medication, we escalate to Step 3, which is a surgical procedure called a left cardiac sympathetic denervation, or colectomy. This literally involves cutting the specific nerve pathways that trigger the heart. And finally, for our highest-risk patients, those who've survived cardiac arrests or have recurrent fainting despite all this therapy, we implant a cardioverter defibrillator in ICD. Think of it as a permanent internal electrical safety net. Now, treating the acquired form of the syndrome is a bit different, and the golden rule here is beautifully simple but highly effective. You must treat the underlying cause. You immediately stop whatever offending drug is causing the block, or you aggressively correct the mineral deficiency, replacing the missing potassium or magnesium to reset the system. You fix that chemical environment, and the heart's electrical timing usually corrects itself completely, no surgery or implants required. At the end of the day, we have to understand that all of these treatments have one singular vital aim: preventing the ultimate stakes. When that prolonged QT interval devolves into chaos, it creates a deadly, twisting heart rhythm known as torsade de pointes. Left unchecked, this spirals into ventricular fibrillation, where the heart just quivers uselessly instead of pumping any blood, leading to a complete flatline or asystole and sudden cardiac death. Understanding long QT syndrome really illuminates the razor-thin margin of timing that keeps us alive every second of every single day. And honestly, it leaves us with a pretty intense question to ponder: how many other invisible electrical vulnerabilities are hiding within our own physiology, just waiting for the wrong trigger?